Hello, students, and welcome back to this course in bioethics, Bio 510, part of the Master of Science in Cellular and Molecular Biology. As always, we begin with a small prayer. In the name of the Father, the Son, and the Holy Spirit. Come, Holy Spirit, fill the hearts of your faithful and enkindle in us the fire of your divine love. Amen. Today's topic is ectopic pregnancy, and we can begin right away. Ectopic pregnancy essentially is when the small embryo, the early embryo, typically within the first couple of weeks of pregnancy, implants or lodges in an area of the reproductive tract of the woman that is not the proper place. So we know the proper place for the embryo to implant and grow and develop and to sustain the pregnancy for 9 months normally is the inner lining of the uterus, the endometrium, which is prepared for that during the hormonal cycle of ovulation. But this early embryo can get stuck, as it were, in any number of places. First, we can begin with an ovulation that was not complete, or the follicle did not fully rupture, and that early egg did not go into the ampulla of the fallopian tube where normally fertilization occurs, so that if there was intercourse and the sperm traveled all the way to the ovary, it could actually fertilize the egg in the ovary, a mature egg, and then the small embryo will begin to grow there. It is not the proper place and for an embryo to grow, and the ovary can certainly not sustain a full-blown pregnancy. Or the embryo could get stuck where it got fertilized normally at the ampulla of the fallopian tube, but then did not progress down from the distal end, the long end of the fallopian tube, down the tube into the proper place of the uterus. And so the embryo started growing here, implanting with the trophoblast, embedding into the inner lining of the fallopian tube. It could also occur anywhere along the tube itself, or even at the interstitial region, which is the boundary between the tube and the uterus proper. None of these areas are prepared for holding a pregnancy, of course, and they are high risk and very, very dangerous. Another place where the embryo could lodge is near the cervix itself, at the bottom of the uterus, as it were, near the cervical opening, which again is not fully prepared for sustaining a pregnancy. And so all these ectopic pregnancies are high risk for the mother, because if you fast forward a little bit, the embryo growing and the trophoblast continues to embed into the adjacent tissue of the mother, will start developing a placenta and so forth, and that can actually rupture these areas, rupture the tubes at the different places, or the ovary itself, and cause a massive hemorrhage. Okay, so it is a high risk for the mother, and it threatens the actual life of the mother. In principle, any kind of ectopic pregnancy. Therefore, it has to be addressed medically and see what can be done. All right. Now, the typical ectopic pregnancy is somewhere along the fallopian tube, and typically, so about half of these ectopic pregnancies resolve spontaneously, meaning that the little embryo does not actually have a chance to implant deeply into that tube, and the tube discards the embryo, the early embryo, typically at the blastocyst stage, or maybe even a little later, by that series of movements that I talked about earlier, the peristaltic motion of the tube itself, which could be equivalent to pushing a marble inside a hose, like a water hose, and pushing on one end of the marble and squeezing it down the tube, as it were. That's the peristalsis or peristaltic motion. And so about half of these pregnancies resolve spontaneously, thanks be to God. All right. But what about the other half, where the embryo continues to be lodged there and it continues to grow and develop, endangering the health and the life of the mother? Okay. The typical management is what is known as expectant management, which is watching, monitoring the woman closely, all right? And if it's not resolved, then there has to be some kind of an intervention. Now, most of the time, these pregnancies occur because the tubes are blocked. Either one or both tubes are blocked. It could be scar tissue or from residue from an infection, etc. And therefore, there is a method for determining if the tubes are blocked or not, and that is called tubal patency, all right, or openness. You can think of passage. If the tubes are passing the normal material, matter that needs to go through that tube, either the egg, a discarded egg when there is no pregnancy, right? That overripened egg has to be discarded through the tube. Or the sperm, if there was intercourse, the sperm needs to travel through the tube in the opposite direction toward the ampulla, or the embryo itself. If there was pregnancy, if there was conception, then the embryo has to travel down the tube, and that tube needs to be open, an open passage, and that's called patency. So how to determine the patency of the fallopian tubes? Well, there is a process for that, and the protocol is called a hysterosalpingogram, or HSG for short. Basically, it is inserting a dye with through a flexible tube through the cervix into the uterus, releasing that contrast dye, and then allowing that dye to diffuse into the fallopian tubes, and then photograph that, well, take an ultrasound, a vaginal ultrasound of the dye to see if the tubes are blocked or not, okay? So with an HSG, the patency of the fallopian tubes can be determined. Now, let us consider, back to ectopic pregnancies, what are the most common causes of ectopic pregnancy? Typically, pelvic infections or a previous surgery that may have left some scar tissue behind. A previous ectopic pregnancy also, especially depending on how that ectopic pregnancy was resolved, all right, that could be already a previous ectopic pregnancy, then puts the woman at a statistically higher risk of a subsequent ectopic pregnancy. STDs or STIs, sexually transmitted infections or diseases, can also cause ectopic pregnancy, again because of the inflammation of the tube on the inside. Endometriosis, adhesions can also cause ectopic pregnancy. The most common one is pelvic inflammatory disease, otherwise known as PID. And so for the sake of the interest of time, I'm going to ask you to look up PID, right? What is the etiology of PID? In other words, what is the cause or causes, the set of causes of PID, okay? So moving forward then, symptoms, very important for the woman to be aware of the symptoms, especially if the woman suspects that she might be pregnant. It could be the missed period or breast tenderness, which are associated precisely with pregnancy, nausea, lightheadedness or fainting. This could be associated with some internal bleeding already, right? And a drop of hemoglobin. Pelvic pain, abdominal pain, which is a little higher, all right? Pelvic being the lower part, around the pelvis, the bone, the hip bone. Abdominal or shoulder pain also, depending on where that bleeding, internal bleeding is accumulating, and what kind of nerves that blood is inflamming or irritating. So even back or shoulder pain could also be a sign, a possible sign, a possible symptom of ectopic pregnancy. Vaginal bleeding, of course, and then all of this coupled with a positive pregnancy test, all right, a positive result of a pregnancy test, then most likely there is an ectopic pregnancy going on. So how to diagnose this? How to diagnose it? Well, the first one is a blood test looking for an elevated level of human chorionic gonadotropin, otherwise known as HCG, all right, which is in the blood of the mother, and it's a factor that is associated with pregnancy, early pregnancy. And if there is a suspicion of that, it can be followed up with an ultrasound, typically after 6 weeks of pregnancy or the first missed period. Either, and that ultrasound can either be transvaginal or transabdominal. And this would be the clincher acid wear to see a bulging fallopian tube, then that is a concern. So if the diagnosis comes back positive for ectopic pregnancy, and it has not been resolved, obviously, because the symptoms persist, then there has to be an intervention, okay? And there are 3 treatment modalities available to date. One is chemical, medical, and the other 2 are surgical. So methotrexate is the chemical one, and the other 2 are surgeries, salpingostomy or salpingectomy. Let's look at each one of these, and then at the end we'll do the bioethical analysis after we have the basic biology covered. So methotrexate, as you can see here from the formula, is a 3-ring organic compound that is a competitive inhibitor of folic acid. So it interferes in the normal function of folic acid or foliate in the synthesis of purines and pyrimidines. If you remember from your genetics courses, pyrimidines are the basic building blocks of DNA, right? Adenine, guanine, cytosine, and thymine, and these are the building blocks of DNA. So methotrexate essentially blocks DNA replication, which, as you know, is a prerequisite for the cells to undergo mitosis, right? Before cells undergo mitosis, during that S cycle, during the S phase of the cell cycle, the synthesis cycle, that's what it is, DNA synthesis. In other words, the DNA has to duplicate, has to replicate, and so that the daughter cells will end up with the same amount of DNA, the same number of chromosomes as the original mother cell. And therefore, methotrexate, what it does, it acts on actively dividing cells, mostly actively dividing cells, inhibiting mitosis, all right? At the embryonic level, when we look at embryogenesis, the development of the early embryo, the most rapidly dividing tissue in the early embryo is going to be, of course, the trophoblast and the establishment of a placenta, because that's where the embryo is going to get its nourishment, number one, and also get rid of its toxins, the product of metabolism, which is a very high-speed metabolism, considering that within 9 months, that little embryo is going to grow about 5,000 times its original size, right, as we spoke earlier. And so you can see that methotrexate, essentially what it does is dysfunctions the placenta, and the placenta being a vital organ of the embryo, temporary, discarded at birth, but during the 9 months is certainly a vital organ for the embryo or the fetus. So going after the placenta and essentially destroying the placenta will in effect kill the embryo. All right, so it is a direct attack on the embryo that is developing in the wrong place, of course, because it's an ectopic pregnancy. But methotrexate, bottom line, kills the human embryo. In contrast to that, there is salpingostomy. If methotrexate, and the typical protocol is they try methotrexate first, especially if the ectopic pregnancy is detected early on and the embryo is small enough to be killed with the methotrexate, and then the body, the reproductive organ, will essentially discard that tissue, or maybe reabsorb also from the inner lining. Contrast to that is salpingostomy. So if methotrexate did not work, for example, and the pregnancy persisted, then, or if it's too far advanced that the dosage would not be proper, then salpingostomy is essentially a horizontal cut, incision on the fallopian tube, longitudinal cut on the fallopian tube, and then the entire embryo is extracted, right, with forceps. The entire embryo is extracted, and then the tube is left to heal by itself, as opposed to being sutured by anastomosis or something like that. Why do you think that this tube is left to heal on its own as opposed to being sutured? If you think about it at the microscopic level, on the inside as well as the outside of the tube, with suturing there will be bumps and bulging tissue, certainly on the outside, but also into the tube itself. And that bulging can actually cause a subsequent ectopic pregnancy, okay, because then it would be equivalent to scar tissue or something like that on the inside. So typically, especially if the incision is small enough, it's a longitudinal tissue along the line, if you will, the natural line of the tissue of the smooth muscle, and therefore it is left to heal on its own down to the cellular level, which would be a more seamless repair, if you will. Okay, that's all at the biological, at the medical level. Let's look at salpingectomy. Bottom line here on salpingostomy, as far as the embryo is concerned, you can see that actually it is a direct attack on the embryo also, because here with the incision, it is going after the embryo itself. They call it the products of conception, which is, again, you have to be very careful with these euphemisms, but the product, what is the normal product of conception, is an embryo, right? It's in the early stages, beginning with the zygote, and then morula, blastocyst, gastrula, etc. So truly it is removing the early embryo that has lodged in the wrong place of the reproductive tract. Okay, finally, salpingectomy. It is the removal of the actual tube, of the fallopian tube, that is pathological now because it has this embryo that has implanted in the wrong place, okay? So the difference here with salpingectomy is that there is really no direct attack on the embryo as a whole, all right? Rather, it is the tube that, because the tube is pathological, then the tube itself is removed. The pathology is removed, okay? Obviously here, the unintended but foreseen consequence of a salpingectomy is that the embryo will die. Inevitably, the embryo will die. However, there is no direct intervention on the embryo as a whole, okay? It is rather addressing the pathology of the tube itself, and then that is addressed by excising the tube. Okay, so based on that, now let's look at the bioethical analysis. What do we have? Considering, as I have stated in previous lectures of this course, that human life begins at conception and that we already have a human embryo by the time these embryos are implanting in the proper or improper place of the reproductive tract, we already have a human embryo as such. And so a direct intervention of the human embryo is not ethical, is not bioethical, because it is killing an innocent human being. Okay, and so, in contrast to that, if the intervention is on a pathology, the pathology being the tube itself, is not the embryo that is pathological, right? The embryo is just following normal development, but the embryo happens to be in the wrong place, and so the pathology is really with the tube itself. That is not the proper place for sustaining a pregnancy, and therefore, intervening on the pathology, then that is a good medicine as such. And drastically, with this particular intervention, the state of the art today, all right, with salpingectomy, is that the embryo will die. That is, but is a secondary effect. In other words, it is not the intention of the surgeon when she or he removes that tube. It is not the intention to kill the embryo. In fact, the embryo is not touched at all, but sadly, the embryo is lodged within the tube, and that is pathological. And therefore, from this perspective, methotrexate protocol or salpingostomy would not be considered a bioethical solution, but salpingectomy is a bioethical solution. All right? Now, considering our contemporary ethos, medical ethos included, what happens is that the most expedient method and easiest method is methotrexate, and even salpingostomy as a second resort. Why? Because that tends to leave the tube more intact or more functional. Let's say with methotrexate, the tube is not cut at all right? And so it's not compromised that way. It can be seen as less invasive to the reproductive tract of the mother, of the woman. And so there is a higher possibility that the woman could get pregnant again, or in principle, it leaves both tubes intact, all right, or functional in principle, whether it's methotrexate, and that's also the intention with salpingostomy. In other words, only remove the embryo, but leave the tube to heal for itself, and hopefully that blockage will not happen again. Okay, so you can see that clinically, medically, there is a tendency, especially with the utilitarian, pragmatic culture, prevailing culture, to use either methotrexate or salpingostomy to resolve a ectopic pregnancy, whereas salpingectomy seems to me more invasive to the woman and more damaging, and in principle it is, because you're removing one of the two tubes, assuming that the other tube is functional. It doesn't render the woman fully sterile, infertile, but it does diminish, you can say by 50%, her chances of getting pregnant again, right? She still has one functional tube, and so everything else being equal, she could get pregnant again, but her chances are diminished. Now, this is still theoretical. In practice, you really have to go patient by patient, because it could have been that since this tube is where the pathology occurred, all right, then maybe this other tube is not as blocked, all right, as this one here. Let's say facing the diagram right now, facing the diagram, the left tube was pathological, all right, but maybe the right tube is not pathological, and so it's not just 50-50, maybe there's a better than 50% chance for the woman of getting pregnant if the right side of her reproductive tract is more functional than the left side, all right? So you're removing a tube that was already predisposed, negatively predisposed, if you will, let's say by blockage or scarring or whatever. The converse could also apply. The opposite argument could also apply. It could be that, yes, this tube was blocked, but you know what? The right tube actually is even more blocked. And so by removing the tube that was less blocked, all right, then the chances are even less than 50% that she will get pregnant, because now she only has the more blocked tube left behind. Right? And so really at the end of the day, in this theoretical 50% reduction of fertility is very, very theoretical, okay? And at the end of the day, you really have to go patient by patient, and there's a whole series of factors that weigh in on the remaining fertility of this woman. But it's not necessarily 100% infertility, as would be, for example, with a cancerous uterus and she undergoes a hysterectomy. Well, then there's not going to be any fertilization there, right? So as drastic as it may seem, or more invasive as it may seem, salpingectomy, all right, really from this bioethical perspective, is better medicine than salpingostomy or methotrexate, because what is underlying here with methotrexate or salpingostomy is that we only have one patient, we're only dealing with one patient, namely the mother who has an ectopic pregnancy, okay? But the other patient is not being considered. Whereas in salpingectomy, the understanding is, from the start, is that there are two patients involved here. There are definitely two patients, you know, otherwise why go through a salpingectomy if you can go through a salpingostomy, right? So there are two patients involved, and because this is a serious condition, this is a life-threatening condition, then it's about, at least, it's a type of triage, you know, it's saving the life of the one who can be saved with the state of the art, which is removing the pathology. Okay, and so it's saving the life of the one who can be saved. It could be that in future medicine, this little embryo could be rescued, all right, without significant risk to himself or herself, and be reimplanted into the mother's uterus, since that mother's uterus would be predisposed in principle for a pregnancy, because the pregnancy did happen, you know, fertilization did happen, and the proper hormones kicked in to thicken the endometrium and so forth, so it would be recipient to the embryo. So perhaps in the future, in future medicine, this little embryo could be rescued from here without significant harm and implanted in the proper locus where he or she was supposed to go to begin with, all right? So you see that when we consider that in an ectopic pregnancy, there are really two patients involved instead of one, then salpingectomy is a better protocol, is better medicine, because at least the embryo is unharmed. Whereas in these two cases, previous cases, methotrexate or salpingostomy, the embryo will be killed, okay? Not just die passively as a side effect of the drastic procedure, but the embryo is actually the primary target of the procedure. All right, and so again, the bottom line about this is that in salpingostomy and methotrexate, the intention is a direct intervention of the embryo to kill the embryo, because the embryo is alive, and it is the alive embryo that is causing that pathology, right? And therefore kill the embryo one way or another, either chemically or surgically. Whereas in salpingectomy, the consideration is, first of all, that there are two patients here. One can definitely be saved by the procedure. The other one, for now, cannot be saved yet, but at least there is the peace of conscience that there was no direct intervention on that second patient. That second patient was allowed to die, because that second patient was going to die anyway in that situation because the pregnancy is not sustainable there. All right. So this second patient, in the natural course of that ectopic pregnancy, was going to die anyway. All right. But at least it was not killed. Okay, my friends. So this is the lecture for ectopic pregnancy. I'm going to finish it now and then post the YouTube so that you can work on your summaries. Thank you once again, and now I'm going to stop the recording. All the best.